Hey everyone, welcome back to Medfoxes. In this Cardiac Pacemakers Beginner's Guide series, we're moving on to an essential topic, pacing indications and introduction to pacing system. Understanding when and why pacing is needed, along with the components of a pacing system, is key to mastering pacemaker therapy. Let's get started.
To begin with normal sinus rhythm, when the electrical impulse in the heart is initiated by the SA node, which is the chief pacemaker of the heart, it is called sinus rhythm. To say it is a normal, it should meet some of criteria, like it should be within 60 to 100 beats per minute, and the rhythm should be regular, and every P wave should come before the QRS complex, and also the PR interval, it should be 120 to 200 milliseconds. In terms of seconds, it is 0.1 to 2.20 seconds, and QRS interval should be 60 to 100 milliseconds. Then only it is called as a narrow QRS. Uh, the conduction system of the heart begins from the SA node, which is the chief pacemaker of the heart. From the SA node, once the impulse is generated, it is transmitted to the AV node via three internodal tracts, and after a short delay in the AV node, the electrical impulse is transmitted to the right and left ventricle with the help of his bundle and right and left bundle branches, and finally the impulse is dissipated in the Purkinje network, which is a distal conduction system of the heart. The pacemaker is an electrical device which stimulates the heart in the absence of intrinsic heartbeat. Let's see who will benefit from the pacing therapy. Since the pacemaker can control cardiac output by controlling the rate of the heart, patient whose cardiac output is low as a result of low natural heart rate and whose lowered cardiac output is unable to meet cardiac output requirement of the body will benefit from the pacing, as it restores the patient cardiac output to meet its demand. Patients with symptomatic bradycardia also benefit from the pacing therapy. When bradycardia results in reduction in cardiac output severe enough to cause symptoms and affect the lifestyle of the patient, it is known as symptomatic bradycardia. A number of cardiac arrhythmias may result in bradycardia, like sinus node dysfunction, AV conduction problems. The sinus node problem, generally we call it as a sinus node dysfunction, encompasses a variety of impulse formation and conduction problems, including sinus bradycardia, sinus arrest, sinoatrial block, sinoatrial block, supraventricular tachycardia, alternating with a period of bradycardia, or we used to call it as a tachybrady syndrome, chronotropic incompetence. When the symptoms are present, the term sick sinus syndrome is also used. As many as 30% of population will have additional conduction abnormality elsewhere in the conduction system. In case of sinus bradycardia, the heart rate is consistently less than the 60 beats per minute, and the patient is symptomatic. The common symptoms include dizziness, fatigue, dyspnea, palpitation, and confusion. The rate will be usually fall between less than 55 beats per minute, or 50 beats per minute. Even the recent guidelines is 60 beats per minute, and the PR interval is more or less 180 milliseconds. We can see in this tracings the interval between the two QRS complex, or even up to PV, it is around 50-55 beats per minute. with a PR interval of 180 milliseconds. Next is a sinus arrest. This is actually a transient lack of impulse formation from a SA node, followed by a period of ventricular asystole or very low ventricular rate. There is no relationship between SA node passes and the basic cycle length. You can see in this tracings. In the diagnosing and the prescribing therapy, the length of the pass are not as important as severity of the patient's symptoms. The common symptoms include syncope, dizziness, fatigue, dyspnea, palpitation, and confusion, more or less same like sinus bradycardia. Next is a sinus bradycardia with sinus pass, also called sinus exit block, sinoatrial node exit block. Sinus bradycardia with the sinus pass. This patient exhibits heart rate consistently less than 60 beats per minute with a transient sinoatrial block. The common symptoms include almost similar syncope, dizziness, fatigue, dizziness, palpitation, seizures, and confusions. Tachybrady syndrome. It's also an important indication for pacemaker implantations. Here, the patient will have intermittent episodes of slow, that is less than 60 beats per minute, and suddenly the rate becomes accelerated to more than 100 beats per minute from SA node or atria during a period of low or moderate exertions. The common symptoms include syncope, dizziness, dyspnea, palpitation, tightness in the chest, seizures, exercise intolerance, confusion, and fatigue. You can see in the strip, in the strip, there is a too complex bradycardia followed by the sudden acceleration of sinus node, which is like a tachycardia. It's more or less seems to be a supraventricular tachycardia. Next in the line is the atrial flutter. So the atrial flutter is a transient or persistent fast atrial rate, which is the rate is usually between 250 to 350 beats per minute with a controlled ventricular response. The P wave is usually is like a sawtooth appearance with a 2:1 or 3:1, even a 4:1 block. The common symptoms include syncope, dizziness, dyspnea, palpitation, seizures. If it is untreated, it leads to congestive heart failure. You can see in this tracings, the atrial rate is that is between the P waves, which is more than 300 beats per minute, and the ventricular rate is fixed at 33 beats per minute. Atrial fibrillation, a chaotic activity of atrium. You see, it's also a transient or persistent fast atrial rate greater than 350 beats per minute and ventricular rate that is irregularly irregular. The P wave will be very difficult to distinguish, or more or less the P wave will not be present in almost all times because of this chaotic activity of the atrium. So the common symptoms include syncope, dizziness, dyspnea, palpitation, seizures, congestive heart failures. You can see in this ECG, the ventricular rate is very irregular and it doesn't have any P wave. We cannot see any P wave in front of QRS complex, and so the atrial rate is more than 350 beats per minute because so not able to identify the P waves. The reason why the P wave could not be identified from this tracing is the atrial rate is very fast, so it is so difficult to detect the P wave. Most of the time it is merged in the QRS complex, T wave or following complexes. The pacemaker indications are classified into many ways. In suitable patients, permanent pacing helps relieving symptoms by restoring a healthy rhythm and improving cardiac output. It may also prevent the emergence of dangerous ventricular arrhythmias that results from bradycardia. The decision to implant permanent pacemaker is based on the classifications of patient symptoms and cardiac disease states. Guidelines are set by ACC, AHA, and HRS. Pacing is indicated only when symptoms correlated with changes in ECG. The class 1 indications are based on evidence and our general agreement that permanent pacemaker should be implanted. Class 2 indications is divided into two, Class 1A and Class 2B. Class 2A is weight of evidence, opinion is in favor of usefulness and efficacy. Class 2B is also a usefulness and efficacy is less well established by evidence opinions. Class 3 is a condition for which there is a general agreement that a pacemaker is unnecessary. In addition to classifications, recommendations that are evidence-based were added to descriptions. For example, Class 1 indication for symptomatic third-degree AV block was designated with level of C evidence. For the sake of brevity, this presentation will not include evidence-based recommendations. Evidence supporting current recommendations are ranked as level A, B, and C. Level A are data derived from multiple randomized clinical trials involving a large number of individuals. Level B is a data derived from a limited number of trials involving comparatively small number of patients or from well-designed data analysis of randomized studies or observational data registries. Level C is experts' consensus opinion was primary source of the recommendations. Based on the available guidelines, the sinus node dysfunction patients will receive the pacemaker in following circumstances. The class 1 indications for sinus node dysfunction is symptomatic sinus bradycardia and symptomatic chronotropic incompetence. Class 1 indications documented symptomatic sinus bradycardia, including frequent sinus spasms that produce symptoms, may be due to long-term therapy of a type and a dose of which they were not accepted alternatives. Symptomatic chronotropic incompetence of sinus node. Class 2 indications in case of sinus node bradycardia is divided into two. Class 1A is symptomatic patients with a sinus node dysfunction and documented rate of less than 40 beats per minute with a clear-cut association between significant symptoms and bradycardia. Class 2B is minimally symptomatic patients with a chronic heart rate of less than 40 beats per minute while awake. The class 3 indication in case of sinus node dysfunction is asymptomatic sinus node dysfunction, that is a sinus bradycardia, say block or sinus arrest. Also sinus node dysfunction with symptomatic bradycardia due to non-essential drug therapy. Sinus node dysfunction in patient with symptoms suggestive of bradycardia that are clearly documented as not associated with a slow heart rate. According to ACC/AHA guidelines for implantation of cardiac pacemaker and arrhythmia devices, these guidelines are stated. Let's see some of electrical problems which is other than the SA node, which is indications for a pacemaker implantation. Mainly it is AV nodal problem. The AV nodal problem is classified into three categories. They are first degree AV block, second degree AV block and third degree AV block. Second degree AV block is further divided into Mobitz type 1 and Mobitz type 2. AV block in the sense the electrical impulses are blocked at the atrioventricular node. The first degree AV block. In first degree AV block, the AV conduction is delayed, but impulses from the atria are blocked in the route to the ventricle. So the PR interval is prolonged more than 200 milliseconds in resting adult. Patients are usually asymptomatic, so pacemaker are rarely indicated. However, there is evidence of AV nodal degeneration. Pacing may be required in future should higher level block develop. This is mostly degenerative, age related. You can see in these tracings, the interval between P and R is constant, which is more than 200 milliseconds. In type 1 second degree AV block, it's also called Mobitz type 1 or Winky back. The intermittent failure of atrial depolarization to reach the ventricle. In type 1 is also called Mobitz type 1 or Winky back. Progressive prolongation of conduction, that is a PR interval, until the ventricle beat is dropped. That means a no QRS complex. AV node is most common site of type 1 block. Its common symptoms include dizziness, confusion, exercise intolerance, and palpitations. You can see in this tracings the first QRS complex, first PR interval, that is the interval between interval from the beginning of P wave to the beginning of R wave is 200 milliseconds. The interval, this PR interval is progressively prolonging. You can see the next beat it is around 360 milliseconds and followed by it is 400 milliseconds, and there is the drop, which means there is no QRS complex followed by the P wave. So this condition is called winky back, so progressive prolongation, sudden drops out. In type 2 second degree AV block, that's a Mobitz type 2 AV block, results in consistently dropped ventricular beats. That means 2:1 block. Let's say every other ventricle beat is dropped. 3:1. Every third beat is dropped, and 4:1. It's a block, etc. This block is most common site. The his bundle is the most common site of type 2 AV block. The common symptoms include syncope, dizziness, and palpitations. You can see with the type 2 second degree AV block, the PR interval will not prolong progressively. The PR interval will be fixed at certain level. So you can see in this tracings, the PR interval is fixed, followed by sudden drop beat. There is no QRS complex. The P wave is not followed by the QRS complex. So usually the site of the block will be the his bundle, um, which is emergency situation. These kind of blocks need to be treated as early as possible. The next and the dangerous condition is a third degree AV block. That's a complete heart block. The no impulses are conducted from the atria to ventricle. An independent site like ectopic foci in the conduction system, example his bundle or Purkinje, usually takes over to maintain the ventricular rate of 20 to 40 beats per minute. This may be acquired, iatrogenic, or congenital conditions. Almost always require pacemakers. You can see in this tracing, the atrium is conducting on its own and ventricle is conducting on its own. There is no relationship, there is no association between P and QRS complex. Sometimes the P wave is merged in the T wave. These common symptoms include syncope, dizziness, fatigue, palpitation, exercise intolerance, etc. Most of the time, the rate will be around 30 to 40 beats per minute.
That wraps up part 1 of this topic in cardiac pacemakers, a beginner's guide. Link to part 2 of this lecture is in the description. Head over there to continue your learning journey. And when you're ready to test your understanding, visit our website to access two powerful assessment tools: a comprehensive knowledge assessment featuring over 500 MCQs based on the entire video series. An IBHRE-style exam simulation consists of 5 blocks, 40 questions on each block, timed to help you sharpen your time management for the real exam. These assessments are ideal for board exam candidates and healthcare professionals alike, whether you're aiming for IBHRE, CCI, EHRA, or just want to solidify your rhythm management expertise. Check the description for all links and start challenging yourself today. If you're enjoying this series, like, share, and subscribe to Medfoxes. It really helps us grow and reach more learners. Thanks for watching, and I'll see you in the next one.